It's my pleasure to introduce our next speaker, Mr. Sawrna Kamal, sir. He is an optometrist currently serving at Sheikh Sultan bin Zayed Hospital in the United Arab Emirates. Mr. Kamal is also the president of the United Optometrists Forum and the chairman of the Optoverse Conference and Exhibition in Dubai. Today, he will be discussing an important topic, surgical impact on the ocular surface and post-refractive surgery related dry eye. Mr. Kamal, sir, we are ready to hear from you.
Thank you, Ms. Fatima. Am I audible?
Yes, sir, you are audible clearly.
Okay. Hello, good evening, everyone. I am Sawrna Kamal here from Sheikh Sultan bin Zayed Hospital, currently heading United Optometrists Forum. Today, my session overview, post-refractive surgery dry eyes. Welcome to our little party today. Yes, the welcome party where I present and you pretend you are excited about dry eyes. How many of you really excited about this topic? Can you please put a thumbs up so that I will come to know how many you are really interested today? Now, speaking of parties, you know how sometimes you go to a party expecting fun, good food, maybe a selfie with nice lighting, but instead you walk into something very different. Well, post-refractive surgery dry eyes is kind of like that. You sign up for the LASIK thinking great vision, here I come, but then your eyes throw their own party. It's an unwelcome party. There is irritation, there is a burning, there is gritty feeling, ocular dryness, fluctuation of vision, photophobia, and sometimes pain. Like your eyes invited sand as a VIP guest. But don't worry, unlike some awkward parties, this one has an exit plan. So let's move forward and see how often unwelcome dry eye party happens, and more importantly, how we can do to turn it back into a comfortable, enjoyable, fully catered welcome party for your vision and your life. We'll start with incidence and risk factor. After LASIK surgery, dry eyes are like an unwelcome party crashers, propping up with 36% to 75% of cases. Nearly everyone gets a taste of this dryness right after the procedure, with symptoms hitting a high score note that first week. For 8% to 48%, the dry spell can last up to 6 months. If you already have dry eyes, you are rolling the dice, as 8% to 55% report symptoms even before the surgery. Other pre-surgery culprits upping the dry eyes odds include high refractive errors, being a female or a bit older, and rocking those contact lenses in the parties or daily uses. So let us commence today's discussion by establishing the context. We will be exploring the intricate details of the post-refractive surgery dry eyes, beginning with an introduction to the troublesome condition, which you did already. To start, we will delve into anatomy and physiology of the cornea. Understanding these fundamentals will serve as a roadmap to identifying the underlying cause of dry eyes following the surgery. Next, we will present a comprehensive pre-surgery checklist filled with essential tips to prevent dry eyes. This information is invaluable for both practitioners and patients alike. So let us start with different kind of refractive surgery currently available in the market. I will not go deep into the subject, just an overview only. The PRK, photorefractive keratectomy, or significant refractive surgery technique. First, we have the removal of the epithelial layer, which exposes the Byman's layers and the anterior stroma. This step is crucial as it prepares the cornea for the next phase, the excimer laser ablation. The laser reshapes the cornea by removing the precise amounts of tissue, enhancing the vision correction. Following this, mitomycin C, an agent that helps prevent haze formation, is applied. This is an important step for ensuring better healing outcomes, of course. Finally, a BCL, bandage contact lens, is placed to protect the cornea during the epithelial regeneration phase. This phase is vital as the epithelium regenerates to cover the treated area, promoting healing and comfort the patient. Next, the LASIK laser-assisted in situ keratomylosis involves several critical steps. First, we have the creation of the corneal flap. This delicate process involves making thin flap in the cornea. Next, the flap is carefully elevated to expose the underlying corneal tissue. This is followed by the excimer laser ablation, where precise amount of corneal tissue are removed to reshape the cornea and correct vision. Once laser has done its work, the flap is repositioned over the treated area, acting like a natural bandage. This promotes immediate postoperative stabilization, which is crucial for the recovery. Last in the list, SMILE procedure, which stands for small incision lenticular extraction. This is a minimally invasive refractive surgery technique. First, we have the intrastromal lenticule creation, where a precise lenticule of the tissue is formed within the cornea using the femtosecond laser. Next, the creation of the corneal cap allows access to the lenticule. Then a side cut incision is made, which is typically smaller than required for the LASIK surgery, reducing potential healing time. Following this, lenticule plane dissection occurs, separating the lenticule from the surrounding stromal tissue. Now, the lenticule is carefully extracted through the incision, a key differentiator from the procedures. Finally, the cap is repositioned and allowed to settle, completing the process. This method generally results in less disruption to the corneal surface and fewer complications, of course. So before going further, you need to understand what is the corneal nervous system. So the cornea is wired like a high security sensory network. It comes from the ophthalmic division of the trigeminal nerve, traveling through the long ciliary nerves. They enter the cornea from all the direction at the edge, then shades their insulation as they move inward. Inside the cornea, these nerves branch into stromal plexus, spreading like a tree roots through the deeper layers. From there, they climb upward through the Bowman's layers, and from there, this form the subbasal nerve plexus, a thin, elegant wave arranged in a spiral pattern just beneath the epithelium. Fine nerve endings then reach the surface of the epithelium, giving the cornea its remarkable sensitivity, like so sensitive that even a tiny eyelashes can feel like a major event. This dense neural network does not just detect the pain, it helps control blinking, tearing, and supports the healing and also nourishment of the corneal surface, keeping vision clear and comfortable. So dry eye after corneal refractive surgery results mainly from the corneal nerve transaction, which disrupts the cornea blink reflex and lacrimal functional unit, reducing tear secretion and destabilizing the tear film. But the extent of nerve damage differs among LASIK, PRK, and SMILE, different kind of surgeries. If we consider the multifactorial etiology, the primary cause, of course, the corneal nerve transaction, disrupts the cornea blink reflex and the ocular surface lacrimal gland loop, leading to decrease the tear secretion. Loss of neurotrophic support negatively impacts ocular surface health, reduce blinking, and worsen meibomian gland dysfunction. So now we know the root cause of the dryness occurring post-refractive surgeries. Now let's see which surgeries affects most and why. First, we'll consider the LASIK, where the flap creation cuts through the subbasal nerves around 300 to 310 degree. Excimer laser ablation damages deep stromal nerves. The majority of nerve damage correlates with the highest risk of dry eyes. Whereas SMILE, no large flap is created, only a 25 to 50 degree microincision is made. Nerves are resected solely at the incision and the lenticular area. The subbasal plexus is primarily preserved. Reduced nerve injury leads to quicker recovery. Whereas PRK, there is no flap, only the epithelium is removed. The subbasal plexus remains largely intact. This method offers the fastest corneal reinnervation. Now, wound healing in the cornea triggers a neurogenic inflammatory response due to the corneal nerve injury. When nerves are cut or stressed, they release some neuropeptides such as substance P or CGRP, which stimulate the surrounding cells to produce IL-6 like interleukin 6 or MMP9 like matrix metalloproteinase 9 or NGF like nerve growth factor and other inflammatory mediators. These molecules contribute to pain, edema, tear film instability, and delayed healing. Now, if we consider the goblet cells, the suction ring used during the lasing and smile compressed and briefly cuts off the blood flow to the conjunctival tissue, which crosses the goblet cells and reduce the mucin secretion. If mucin secretion is reduced, so of course increase the tear film instability. Femtosecond LASIK causes more goblet cell loss than a microkeratome LASIK because it uses stronger suction, longer suction time, and more surface compression. Tear film instability from corneal shape change, like post-operative corneal flattening alters the natural curvature needed for the smooth tear distribution. As a result, the tear film spreads less evenly and breaks up faster, increasing evaporation. This contributes directly to evaporative dry eye and after refractive surgery. Toxicity from the medication, frequent use of post-operative drops, especially those containing preservative like benzalkonium chloride, BAK, can irritate and damage the corneal and conjunctival epithelium. This reduces surface health and mucin production, worsening tear instability and aggravate post-operative dry eyes. Meibomian gland dysfunction (MGD). After surgery, patients often blink less due to discomfort or photophobia, leading to reduced meibum expression. Additionally, the altered corneal curvature changes lid cornea interaction and impairing lipid layer distribution. Together, these factors weaken the lipid layer and promote rapid tear evaporation. So, increase post-operative dry eyes. Here are some pictures from the confocal microscopy, few images. So, if we think about the management, the tear substitute like the preservative free, of course, that our previous speaker already discussed about this one, artificial tears, used as a first line of therapy to replace and stabilize the tear film after the surgery. They provide quick relief from the dryness caused by the temporary reduction in corneal nerve function and tear production. Topical anti-inflammatory agent like steroids, cyclosporine, etc. This reduce post-operative inflammation that contributes to dry eye. Steroids help in the early healing phase, while cyclosporine improve long-term tear production and ocular surface health. Another option is punctal plugs inserted into tear ducts to retain the natural tears on the eyes for longer period of time. Useful when the tear production is low after surgery or when artificial tears alone are insufficient. Now, mucin stimulators stimulate the mucin production to improve tear film stability and spreading the tear all over the cornea. It is beneficial when mucin deficiency or tear film instability persists after the refractive procedure. Autoglobus serum tears made from the patient's own blood. This drop contains growth factor that promotes surface healing, used for the moderate to severe postoperative dry eyes, which are not responding to the standard treatment protocol. Other formulations like lipid-based tear or hyaluronic acid or gels, etc., support specific tear film deficit. Lipid tears improve evaporation or resistance. So we can see in our hospital we are following this pre-operative checklist where post-operative dry is a common and impactful complication for corneal refractive surgery with a variable course influenced by surgical technique and patient-specific factor. So proper pre-operative assessment and individualized management strategies are vital for improving patient outcome and satisfaction. As we know, prevention is better than cure. Here I am presenting a complete pre-operative checklist. First, the Sawrna test, type 1 and type 2. Sawrna type 1 is conducted without anesthesia, measuring the total tear production like both basal and reflex tearing. And Sawrna 2 conducted with anesthesia, like it assesses the reflex tear secretion only. Then tear film breakup time, TBUT, assesses the tear film stability by measuring the time between a blink and the first dry spot on the cornea after the fluorescent dye is instilled. A TBUT less than 10 seconds suggests unstable tear film and is commonly associated with the evaporative dry eyes. Then in picture E, you can see tear meniscus height, TMH, the height of the tear meniscus at the lower eyelid margin. Usually we can measure this one with the slit lamp or imaging. It reflects tear volume, and a low volume of TMH like less than 0.2 to 0.3 millimeter suggests aqueous deficiency, dry eyes. In picture D, you can see non-invasive breakup time, NIBUT, where we measure the tear film stability without using the fluorescent dye, typically using the keratography or placido-based imaging. It records the time between the complete blink and the first distortion of the reflected rings. Shorter NIBU indicates the unstable tear film and early evaporative dry eyes. Blink rate is the number of times person blinks per minute. A reduced blink rate, commonly seen in the prolonged screen or digital device user, can lead to increased tear evaporation and dry eye symptoms, while incomplete blink also contributes to ocular surface instability. Blink type can be divided into four, like either is complete blink, incomplete blink, spontaneous, or is a voluntary blink. Punctal stenosis or obstruction can cause epiphora, excess tearing, that we also need to check in the slit lamp. In the picture I, you can see the meibomian gland dysfunction and blepharitis, which can aggravate the dry eye syndrome. Picture J, tear debris refer to the particular matters like mucous stands or cellular remnants visible in the tear film in the slit lamp during the slit lamp examination. It is often seen in a dry eye or ocular surface diseases, indicate tear film instability or inflammation. Clinically, it can contribute to blurry vision, foreign body sensation, and discomfort, and its presence should be noted during the preoperative assessment of the refractive surgery. So my take-home message for the dry after the refractive surgery, like dry is the most common post-refractive surgery complication arising from the combination of corneal nerve damage, inflammation, tear film instability, goblet cell loss, meibomian gland dysfunction, and changes in corneal shape. Extent of nerve damage varies by procedures with PRK and SMILES showing faster corneal re-innervation and milder symptoms. Neurogenic inflammation, reduced blinking, and preservative exposure further worsen tear film stability. Preoperative evaluation and ocular surface optimization are essential to minimize postoperative dry eyes. Management is multifactorial, of course, including lubricants, anti-inflammatory therapy, punctal plugs, and addressing meibomian gland dysfunction. Key clinical points like tailoring surgical choice and postoperative care to individual risk factor to improve patient satisfaction and recovery. This all my reference. And thank you all for listening to my talk. Unfortunately, I will not be available for the panel discussion today. I have another important meeting. I am already 15 to 20 minutes late. So if you have any questions or if you want to discuss with me, you can directly email to me in onlysk.on@gmail.com, or you can connect with me in the LinkedIn by scanning the QR code or searching by name also. I promise I'll reply faster than your post-LASIK TR breakup time. Thanks again, and looking forward to continue with the conversation virtually. Goodbye.
Thank you so much, Mr. Sawrna Kamal sir, for your insightful presentation. We truly appreciate your time and valuable contribution. I understand you have another meeting to attend, so wishing you all the best in your next engagement. Thank you, sir.
Thank you.
All our audience. Now we will move into our question and answer segment. So if you have any question, please type them in the chat box. We will take them one by one.